Good afternoon to you all.
Good afternoon.
It's not an easy thing to speak soon after lunch, but I do hope that you are going to follow through in the next 10 to 15 minutes as I take you through the experiences of implementing HPV DNA testing in low and medium income settings, and in particular in Makoni district in Manicaland. So my name is Ngonidzashe Ganje, and I'm a senior technical officer with Zimbabwe Health Interventions, and this is the outline of my presentation. Just as a way of introduction, Zimbabwe Health Interventions is supporting the Ministry of Health in providing cervical cancer screening. We do this in 2 provinces, that is in Manicaland and Midlands, in 9 districts, as part of the care for HIV care and treatment. And the primary screening method, in line with the current Ministry of Health guidelines, is through visual inspection with acetic acid. But we know that in 2021, the World Health Organization issued guidelines for cervical cancer prevention to try and accelerate the elimination of cervical cancer as a public health burden. And in this guideline, human papilloma virus DNA testing is then recommended as the primary screening test, and then triage with visual inspection with acetic acid, and then you provide treatment as indicated, either through thermocoagulation, cryotherapy, or LEAP. So this is the current algorithm for cervical cancer screening in Zimbabwe, where you perform VIAC. If it's negative, you rescreen after 1 year for women living with HIV, and after 3 years for the general population. If it's positive, depending on the type of lesion, you then provide either cryotherapy or thermocoagulation, or you provide LEAP, and you reassess the client after 6 months. If it's suspicious of cancer, these are then referred to tertiary institutions where they are seen by gynecologists and for further management. The new algorithm that we have been using in our pilot in Makoni is whereby you conduct HPV DNA testing as the primary screening test. And this can either be self-sampling, where the woman collects the sample herself, or it can be collected by a clinician. If it's negative, rescreening is after 5 to 10 years for the general population, or 3 to 5 years for women living with HIV. And if it's positive, you basically follow the same algorithm that I've alluded to in my previous slide, where you conduct visual inspection with acetic acid as a triage test. If it's negative, you rescreen with HPV testing after 2 years for general population, and after 1 year for women living with HIV. And if it's positive, depending on the lesion, you can perform ablative treatment, or you can perform LEAP and reassess after 1 year. If it's suspicious of cancer, or if there is actually cancer, you can then conduct further evaluation, biopsy, and management as indicated. So why are we talking about human papilloma virus DNA testing? The uptake of cervical cancer screening remains suboptimal in Zimbabwe. I think if you look at the mortality, it has remained high, with almost over 2,000 women dying each and every year because of cervical cancer, despite us implementing robust programs for screening in terms of VIAC. There are issues around the quality of VIAC programs. You know, it's dependent on the one who's providing the service. How good are they in taking the image? How good are they in interpreting the VIAC image? And so quality becomes an issue. There's also the issue of overtreatment with LEAP. Looking at the results that were being posted by different implementing partners who are implementing VIAC programs, you'll find that over-treatment rates have been ranging from around 30, and sometimes they even go beyond 50%, whereby women who are receiving LIP services are actually not supposed to be receiving these services. There's also the issue of coverage. With VIAC, you need a clinician who's trained. A certain amount of skill is required for one to provide the service. And so it's really limited perhaps to polyclinics and district provincial hospitals. But the majority of the facilities, you actually don't have people who are trained to provide this service. And so those women who actually need the service do not actually end up receiving the service, because they'll be living in those remote areas where they do not have access. On the other hand, HPV DNA testing is more specific, it's more sensitive compared to VIAC, potentially cheaper, cost-effective, and I'm just going to take you through what we have done and some of the results that we have seen. And so we conducted this study just to assess the feasibility of using HPV DNA testing for cervical cancer in remote rural district of Zimbabwe, and those were some of the specific objectives. And so we conducted this pilot in Makoni, as I've alluded to. High vaginal swabs were collected and transported to the laboratory. This was done through self-sampling or healthcare worker collected sampling. And then those clients with a positive HPV DNA test then were linked to visual inspection with acetic acid as a triage test, and treatment was then provided. And so we obtained client level data for the period May to December 2022 using COBO, and analyzed it using Strata 15, and that was our ethical approval. And so in terms of the results, a total of 480 women had an HPV DNA sample collected. Those are the women that we looked at. And in terms of age, majority of them were above the age of 25 years, 95% were 25 years or older. And this is deliberate because in our program, we do target women from the age of 25 to 49, as these are the women who are at high risk. But we also don't exclude women who are outside this age group, women who are younger, knowing that in Zimbabwe we do see cases where women as young as 9, 14, 15 are sexually active, some of them living with HIV, and so by the time they get to 25, they can be at risk. And so we also just screen them as they come, but in terms of targeting, it's 25 and older. And then of those, for the women who are below 25, 74% of them opted for self-sampling, while 26% had a healthcare worker collected sample. And the same pattern followed for even the older women. In terms of turnaround time, from the facility to the lab, and in this case, lab is referring to the hub, which is Rusape General Hospital, our turnaround time was 1 day. So we did leverage on the integrated sample transportation system, which is existing for transport of viral load samples. So for majority of the sites, the rider visits usually at least every 3 days in a week. So on the day that the rider is scheduled to come, the HPV DNA samples are collected and are then transported to the lab. From the hub to the processing lab, and until results are returned to the facility, the median turnaround time was 26 days with an interquartile range of 17 to 34 days. And in terms from the time the facility receives the results, follow up with the client and provide via triage for those who have a positive HPV DNA test, the turnaround time was 22 days. This is just to show the performance for the same period, May to December 2022, where 480 samples were collected. 33% were actually HPV DNA positive, that's 156, and 60% were linked to VIAC, which is 93. And if you look to the pie chart on the right, it shows that the majority, that's the one in blue, 75% had self-sampling, whereas 24% were collected by the healthcare worker. This is just to try and disintegrate the same information which I've shown on my previous slide, where it's showing that 114 of those who self-sampled tested positive, 224 were negative, and for those that were collected by the healthcare worker, 38 were positive and 67 were actually negative. We note from literature that there isn't really any difference in terms of sample quality for samples that are for self-sampling and for samples that are collected by healthcare workers. I think Chai did a study in Mashonaland East, which also reached the same conclusion even in our setting. And then in terms of self-sampling, it seemed to be preferred by, self-sampling seemed to be preferred compared to healthcare worker collected specimen. And could this be because it's more private? A client gets to take the sample on their own, in their own privacy. Could it be that we are able to go past any cultural and religious barriers that might exist? I remember the story I once shared about the Mahenye issue, where we tried to conduct VIAC, and despite sending teams for outreach, we were not getting women to actually screen, and it was because of their cultural background, where a woman will not allow anyone else to actually examine their genitalia unless if it's for maternity delivery issues. And so reaching out to such places with HPV DNA testing, self-sampling really proves to bridge that gap. And then the long turnaround time resulted in suboptimal linkage to triage, delaying treatment of precancerous lesions. So the longer you take before returning results, before following up on the clients, the less likely that you'll be able to link them to the further care that they might require. Sometimes you will come back with your results a month or 2 months later and the client is no longer there. Maybe they've moved to another place. But we learned that HPV DNA testing is scalable. Secondary distribution is also possible. I think there are partners who have also used lay cadres to distribute the HPV DNA test. So secondary distribution of these testing kits is actually possible. And in terms of our context in Zimbabwe, we can leverage on existing platforms. That is the integrated sample transportation system, which is already existing and is reaching almost all facilities in Zimbabwe, where the riders are able to collect samples, go with them to the hub. They can be moved from the hub to the provincial labs and so forth. We can also leverage on the existing testing platforms in our provincial laboratories, the hologic machines which are there, high throughput, and are able to process large volumes of HPV DNA samples. Also the laboratory information management system in terms of receipt of results. Through that system, we know you are able to send results via SMSs. You are also able to send a notification to the client to go to the facility because their results is actually out. And so it is possible to scale up HPV DNA testing because of these existing platforms. It has the potential to reduce the burden of conducting VIAC. As you have seen, only 33% tested positive. So instead of providing VIAC services to 480 clients, you end up just providing 256 clients. And so we know, I think from the previous speakers, we have mentioned about staff attrition, the burden on healthcare workers, that can potentially be reduced should we scale up HPV DNA testing. It has the potential to improve coverage. We were deliberate in choosing very remote sites in Makoni because we were not previously able to reach them even on a quarterly basis with outreach teams. But with lay cadres distributing HPV DNA testing kits on a weekly basis, we are able to actually reach more women. It has the potential for savings in the long run in terms of cost. And this is not related to our study, but just to show the whole cascade of how we have implemented. So for this period, 616 women had a HPV DNA sample collected. 85% received their result at the time of reporting, with a 29% positivity. And of those who were positive, 85% were linked to the triage test, that's 129 women, and 7% were actually VIAC positive and required treatment. These were 9 women, and of the 9 who required treatment, 7 actually received treatment, with the other 2 at the time of reporting they had been booked for LEAP services. In terms of recommendation, we recommend that we should capacitate our district laboratories, all provincial labs, to be able to process HPV DNA samples. And when that happens, it actually becomes almost possible to be able to scale up HPV DNA testing. And targeted outreach for those women who then test HPV DNA positive are required to actually optimize linkage to the triage test. And then, like I've mentioned, electronic relay of results to reduce the turnaround time, and client SMS notification can also help. We would also recommend that we repurpose funds that we have been channeling towards VIAC programs, buying cameras, expensive equipment to scale up HPV DNA testing. This could be our own domestic funding, or it could be the funding that's coming from partners and different entities that support the ministry. Just to acknowledge those who made this report possible, our funder, the US government, the Ministry of Health that we work for and with at different levels, the program beneficiaries, as well as the Zimbabwe Health Intervention staff. Thank you.
Thank you very much, Dr. Ganje. Okay, please come and take a seat.